Do you want to start?
All right, sure, doctor. Okay, assalamualaikum and good morning to doctor and my fellow friends. My name is Yusuf Daniel. I'll be presenting my part on this HIV seminar. So, okay, I'm very sorry, but the slide is stuck. Give me a moment. Okay. So my content of presentation will cover the introduction, particularly what is HIV and why is it relevant, and then a little bit on the epidemiology of HIV and the modes of transmission. Okay, second part of my presentation will cover the virus structure, the classification, and the morphology. Third part of my presentation will cover the replication cycle. As for introduction, basically just one question that covers this whole part. So what's HIV and why should we care? So HIV, long form of it, it's human immunodeficiency virus. So obviously it causes AIDS, acquired immunodeficiency syndrome, and it is one of the deadliest and most persistent epidemics. You can just search this on Google. What is the most deadliest and most persistent epidemics? It will surprise you. The answer will be AIDS, of course. Sorry, slide is stuck. And mind you, my content of presentation is a very nice to know and general part of the presentation. So just sit back, relax, and warm up your brain for the rest of this seminar that will be presented and covered by Yvonne, Moafa, and Aisha. Okay, so again, what is HIV? It is a virus that attacks the cells that fight the immune system. Okay, and what does it do? It destroys an individual's immune system that eventually leaves them vulnerable to other infections. So and then what? Spreads primarily through bodily fluids, and if it is left untreated, it can lead to acquired immunodeficiency syndrome. Take a look into that. Okay. So what can we do to stop this epidemic? How do we raise awareness? And what policy do we legislate to help stop the spread? These are the questions that you should keep in your mind, as you will obtain the answer to it during my presentation. So also, what does the testing cost? Is it subsidized antiretrovirals? What about the testing prior to marriage? And what is the rising debate of hiding if they have HIV? Okay, so keep those questions in mind first. I will cover the epidemiology of HIV cases right now. So as for 1990 to 2019, it is represented by this graph. So it represents estimated adults and women above 15 years old living with HIV. So we can see two lines here, blue lines and the red line. So the blue line represents adults above 15-year-old living with HIV. So it also covers the number of women, of course. And then the red line only represents a woman above 15 years old living with HIV. So roughly the estimation is about 87,000. And as for the woman living with HIV, it's about 15,000. Not much to be particular on in this graph. Sorry. Okay. And within this statistics also covers the estimation, only the estimation of the HIV and AIDS endemic in Malaysia. So PLHIV represents people living with HIV. So we have a total of 87,581, which is the median number between this range, I guess. So this is a total of, male should be the leading quiet counterpart of the HIV cases, followed by women, and then followed by children. Okay, PNI HIV represents people newly infected with HIV. We have a total of 6,332, which is also the median number between this range. And then we also have obtained the estimated number of AIDS-related death, which is about 2,685. Now, having obtained these estimated numbers, we we illustrated better in this graph. Slide is stuck again. I'm very sorry. Yeah. So it is better illustrated in this graph. Estimated people living with HIV, newly infected with HIV, and number of AIDS-related deaths. So the number that was given in the statistics just now, we round it off. Now we have obtained 88,000, 6,300, and 2,700 for the data obtained respectively. People living with HIV, yeah, newly infected with HIV, and AIDS-related deaths. Okay, so that is for the estimated part of the epidemiology. Now, okay, now here comes the actual number of the HIV and AIDS endemic in Malaysia for the year 2019. So it's a bit, it's it's a bit less than what was estimated. So as for just now, 88,000. The actual number is actually 77,000. So of course, male and female counterpart of the number. So that's for people living with HIV. People newly infected with HIV as for the year 2019. Okay, sorry. It's a lot less as well. So just now we estimated 6,000. So it's actually near to the half of it, 3,564, and 15 cases of children newly infected with HIV, of course. And then the AIDS-related death, we obtained 2K, nearly to 3K now. So the actual number is actually 986. Okay. Excuse me. Okay. So now we represent the cases by states. All right. So in this pie chart, it represents the percentage as for representation of the whole population of Malaysia. So most population of Malaysia that contributes to the number of HIV cases comes to Selangor, of course, followed by basically just focus on these 6 states: Selangor, KL, Johor, Sarawak, Pulau Pinang, and Sabah. Now as for this part over here, they have their whole own independent percentage that represents only the population within the state. I didn't provide the percentage for each state, but if you take KL as a whole and only the population within it, most of the population of KL has a higher percentage that contributes to HIV as compared to the total population of Selangor. Okay, and as for states, as for the whole population of the states, these are the rankings: Kuala Lumpur, followed by Selangor, followed by Sarawak, Penang, Sabah, and Johor. So 12.6% of KL covers a larger percentage to represent the whole KL. If that makes sense. Okay. Moving on. Okay, now we represent the causes of infection by the different types of incidents. And this graph is color coordinated, of course. And as for blue, it represents people who inject drugs, prevalence of cases through people who inject drugs. As for green, female sex workers. As for orange, men who have sex with men, basically homosexual activities. And then as for, let's pick one over here, you know, obtained through sexual activities of transgender individuals. Okay, so as for the cases of people who inject drugs, the highest number is obtained by the state of Kelantan, and the rest of it is KL. Someone in the chat said 3 medals for KL, 1 for Kelantan. Stop that. Yeah, not very appropriate to say that. Okay. HIV incidence by age in 2019. For ages less than 1%, we have obtained a data of 0%. 1 to 14 years old, 0%. For ages between 20 to 29 years old, it's 45%, probably the highest percentage. 30 to 39, just 30%. So doesn't need to be explained. I guess we all understand why it's higher within these age range, and yeah, and of course up to 30 to 39 too, of course. So 70% of the new HIV infections are among 20 to 39 years old, obviously. What I would like to emphasize on, there is a term called mother-to-child transmission of HIV. So if you are a mother with HIV, treatment with antiretroviral therapy can prevent mother-to-child transmission. And I guess the awareness of that have been increased over the years from, I would say, 2006 to 2019. So I guess this contributes to the fact that children are less affected, or like less inherited, like they inherit less of the HIV from their parents. Moving on to the mode of transmission and age group. Okay, as the left hand side, you will see the cases among people less than 25 years old from the year 2012 to 2014, and right hand side, above 25 years old from the year 2012 to 2014. So I'll just emphasize on the year 2014. The largest contributing number of cases comes from homosexual or bisexual activities, and that's for ages less than 25. And for above 25 years old, most of the cases comes from heterosexual activities. So I think it explains quite the obvious differences in our generations. Yeah. Okay. Now we cover a bit larger range between the years 2000 to 2019, and larger cause of HIV infections within this graph. So obviously blue represents people who injected drugs. This sort of magenta color represents heterosexual activities. The green one, homosexual activities. Let's not pay much mind to the vertical line. And then, oops. And then the rest, can't really see the dark green one, but like that represents blood and organ transfer. You can see it's a very fine line over there. Okay, but what I would really like to emphasize on over here is that back in 2000, it used to be very obvious that the leading cause was people who inject drugs. They acquire HIV through sharing the same needle when I don't know, acquiring the drugs. But the reason for this decline for this decline for people who inject drugs because back in 2006, sorry, Malaysia has introduced the needle exchange program, or harm reduction program, which raises awareness in the harm in sharing the drugs, in sharing the needle for the drugs. So obviously that has been successful since the year 2006. You can see, okay, it's a bit rise, but like that has been successful. And also the habit of drug users have changed since then. The illegal drug users now prefer taking tablets such as ecstasy, pill puder, and etc. So the mode of transmission for HIV is now shifted. So the leading cause is shifted to sexual activities. And as for why homosexual cases are becoming an increased risk as compared to heterosexual activities, it's because mind you, if it's with or without protection, but like even if it's with protection for homosexual activities, we don't get no, I'm sorry, not we, but like males, um basically in the anus, they don't get as much um lubricancy in their anus as compared to the female genitalia. So this increases the risk of abrasion based lesions, friction based lesions. And even if there's a bit of an abrasive lesion, that could increase the risk of acquiring HIV by 4 times. So that explains. Now I'll be coming to the mode of transmission. So more than 90% cases are from sexual transmission, like mentioned. 60% of it homosexual, and 30% of it is heterosexual, divided by the ratio. And then, of course, obtained by mostly through anal, vaginal, oral sex. So risk per sexual act, uh, male to female intercourse contributes about 0.1% to 0.05% for females. Male to male intercourse contributes about 0.5% for the receptive partner. Okay, so of course comes with the mode of transmission is the modifiable risk factors. The first one being circumcision. Circumcision overall it reduces the risk of infection and reduces the risk of lesion during intercourse. Because if you have more skin, you get more friction, more abrasion. And then let's say if the receptive partner has a genital mucosal damage, they should bear in mind that that increases 4 times the risk of infection. For example, herpes and syphilis, also including HIV. And then co-infection. So say if the receptive partner already has herpes, HPV, it already increases the local virus concentration. So the modes of transmission, through parental transmission. So needle stick injury contributes about 0.36% per injury. Needle sharing, 0.67% per exposure. So blood on mucous membrane, 0.1% per exposure. And contaminated blood transfusion. This rarely happens, but like as to describe the number of cases, it's 1 in 2 million. Okay. As for pregnancy, like I mentioned just now, mother to child transmission contributes about 5 to 10%. Through breast feeding, 5 to 20%. So even if it's not, even if the baby doesn't acquire it through the placenta, it can also acquire through bodily fluids, breastfeeding. And then through childbirth, of course via C-section as well, contributes about 5 to 15%. And of course, big reason of it is because of the exposure to the mother secretion of blood to the baby. Okay, now I'll be moving on to the viral structure. So But the HIV virus belongs to the family of Retroviridae, the genus antivirus, the species HIV-1 for the global classification. If we want to be particular about the HIV in West Africa, it's HIV-2. So how do we describe the structure? We describe it as icosahedral spike envelope. So it has 9 genes that encode 15 proteins, which we will take a look on after. And then, of course, we already learned of all of this. It says RNA encapsid and pseudo-diploid, and of course, the structural proteins as well that makes up the whole virus. Sorry. Okay, moving on. Give me a second. It's lagging. Okay. So a few genes that I mentioned that we should emphasize on is pol gene, GAG gene, TAG gene, and ENV gene. And what they do, as for the first one, encodes polyproteins, functions as a reverse transcriptase, integrase, and protease. We can sort of consider. Then the GAG gene, it encodes GAG protein, of course, that leads to the formation of P17, which is the matrix protein, and the P24, which is the capsid protein. Then as for the TAG gene, it encodes the TAG protein, which increases viral transcription. And for the ENV gene, it encodes GP160, which contributes to the formation of GP120, which is to attach CD4 plus T cells, the alpha cells. Attaching the virus to the T alpha cells, and then GP41, which contributes to the fusion of cells, into cells. Sorry. Stuck. Okay. So the general picture of the virus, okay, P17 matrix over here, and nucleocapsid. Of course, comes around is the capsid, and comes around the DNA is the integrase, and then the P24 core, which what contributes to the formation of what I mentioned just now, P17 and others. Okay, I believe everyone is familiar with the general structure of the virus, and then the life cycle. Take note of the 7 processes. Of course, the binding, the fusion, the reverse transcription, integration, replication, the assembly, of the whole capsule and stuff, and the budding. Yeah, I'll be going through the process one by one. So first, the binding and the attachment. So viral envelope glycoprotein GP120, which is the tab here, binds to the CD4 receptors. So that's the whole purpose of it. CD4 receptors present on T helper cells. So basically, that's why it's immunodeficiency. It mainly affects the T helper cells, which is the immune cell. Okay, so GP120 and CD4 complex binds to co-host receptors. So cells that are attacked include T cells, macrophages, monocytes, like I mentioned just now. Okay, so that was for the binding. As for the fusion, like I mentioned just now, what contributes to the fusion is GP41. So GP41, where is it? Okay, it's not within the diagram, but it's for the fusion, the HIV envelope and the CD4 cell membrane, they fuse, join together, which allows HIV to enter the CD4 cells. To stop this, there will be on medications, which is the fusion inhibitors, which I will not take a look into. And then the process, reverse transcription. So inside the CD4 cells, HIV releases and uses reverse transcriptase to convert its genetic material, HIV RNA, to become a DNA. So the conversion of HIV RNA to HIV DNA allows HIV to enter the CD4 cell nucleus and combine with the cell's genetic material. So that will proceed into integration, and then just take note of these two. Okay, as for the fourth process, integration. The DNA that was formed just now, it is basically integrated into the host DNA, and that leads to more transcription of the HIV's gene, which leads to, of course, transcription, which leads to translation. So translation contributes larger to the incidence of replication of the HIV gene, and after the replication comes budding. So this is how the number of virus that the recipient gets increases throughout throughout the duration within this whole incidence. So these are my references. If you have any questions, you may come to me now, or else we'll proceed with the next presentation.
Thank you, Yusuf. So I will present about the second session of the seminar. So good morning, doctor. Good morning, everyone. So I will going to present about the natural history, the clinical feature, and also progression and transmission of HIV infection. So at first, what means the natural history of HIV? So before we start, we must know that what is the meaning of the natural history of a disease. It is a progress of a disease process in an individual over time in the absence of intervention, and there are 4 stages, that is susceptibility, subclinical disease, clinical disease, and recovery, disability, and also death. So for the natural history of HIV, it leads to the progressive decline in the CD4 lymphocyte count, and this will increase the risk for opportunistic infection and also malignancy. And it is also involved the median time from infection to the development of AIDS ranges from 8 to 10 years among the untreated individuals. So the infection to the development of AIDS ranges from 8 to 10 years. So the patient will not have any symptom, and we will call it as a latent stage, which I will explain it further in the next slide. So for the natural history of untreated HIV, so during the early period after the primary infection, there is dissemination of the virus, development of an immune response to HIV, and often an acute virus syndrome. So during the period of clinical latency, which may last from 8 to 10 years, the viral replication continues and the CD4 T cell count will gradually decrease until it reaches a critical level below which there is substantial risk of AIDS-associated disease. So HIV disease begins with acute infection, which is only partly controlled by the adaptive immune response, and advanced to the chronic progressive infection of peripheral lymphoid tissue, and the virus will typically enters through the mucosal epithelia, and the subsequent pathogenesis event and clinical manifestation of the infection can be divided into several phases. There is acute retroviral syndrome or middle chronic phases, in which most individuals are asymptomatic, and also the clinical AIDS. So based on Robbins and Ketchum pathology, it divides the HIV infection into four stages. That is stage 1, acute or primary HIV infection. Stage 2, chronic HIV infection. Stage 3, we call it as early symptomatic stage. And for stage 4, it's AIDS. So for the pathogenesis of the HIV infection, The initial infection starts in the mucosal tissues, involving mainly memory CD4 T cells and also dendritic cells, and spreads to the lymph nodes. And the viral replication leads to viremia and also widespread seeding of the lymphoid tissue. And the viremia is controlled by the host immune response, which is shown in the diagram. And the patient will then enter a phase of clinical latency. During this phase, viral replication in both T cells and macrophages will continue to unabated, but there is some immune containment of the virus. There's continue a gradual erosion of the CD4 T cells numbers decline, and the patients will develop clinical syndrome of full-blown AIDS. So let's start with the first stage. That is acute primary infection or acute HIV infection state. So for stage 1, it's referred to the approximate 6-month period following HIV acquisition, and it represents the initial response to HIV infection, which can call it as worst flu ever. Within the 2 to 4 weeks after infection with HIV, about 70% of people will have a flu-like illness. This is the initial body response to fight the infection, and this condition we call it as acute retroviral syndrome. This syndrome is initial manifestation of human immunodeficiency virus, that is HIV infection. So in acute HIV infection, which is a period of rapid viral replication and also infection of CD4 cells, this plasma viral RNA level is typically very high, and the CD4 cell count can drop transiently. So after a few weeks to months, the plasma viremia decline precipitously with seroconversion and development of antiviral response until reach the set point of CD4 will increase. So after 2 to 4 weeks after exposure, the patient may experience a non-specific flu-like illness, as I mentioned by just now. So the example of manifestation of acute HIV infection are as follow. For the first one is the constitutional symptom, such as fever, chills, malaise, or fatigue, night sweats, anorexia, and also weight loss. The lymphatics include swollen lymph nodes, especially in the groin, head, and also neck. For the nose and throat, patient will have sore throat, with or without ulcer or thrush. For gastrointestinal, patient will have nausea, emesis, and also diarrhea. For musculoskeletal, we have asymmetric joint swelling and also tenderness. For the neurologic part, patient may experience personality changes, headache, and also painful or stiff neck. For the minor opportunistic infection, we have herpes zoster or angular cheilitis. So clinically, this phase is associated with cell-limited acute illness with non-specific symptoms. So these are the diagrams to illustrate the sign and symptom. For the first one, the angular cheilitis is a common skin condition, affect the corners of the sores. For the herpes zoster, it's a viral infection that occurs with reactivation of the viral zoster virus, and is usually a painful self-limited dermatomaris. It's very common in HIV patients. For the oral candidiasis, it's characterized by multiple superficial creamy white plaque and is common if hard and soft palate, as shown in the diagram. So these are the main symptoms of acute HIV infection. This is just a summary. So for stage 2, next we're going to talk about stage 2, that is chronic HIV infection or asymptomatic latent stage. So next, the chronic phase of the disease, the lymph nodes and the spleen are the sites of continuous HIV replication and also cell destruction. So during this period of disease, few or no clinical manifestation of HIV infection are present. Therefore, this phase of HIV disease is called the clinical latency period. Although the majority of the peripheral blood T cells do not harbor the virus, destruction of C4 T cells within the lymphoid tissue will continue during this phase, and the number of circulating blood CD4 cells is steadily declines. So in the absence of antiretroviral therapy, ART, the average time in this stage is approximately 8 to 10 years. So for a simple way, the explanation why the stage 2 takes so long is because all the virus destroy the CD4 cells. At the same time, the body will respond by also producing more CD4 cells. This somewhat will compensate it, so there is a rapid turnover of CD4 cells. So high destruction and high production of this. So clinically, we will get clinical latency for up to 10 years. Only after that, the bone marrow is depleted and the body cannot deal with the high destruction. Then they will enter the stage 3, having the constitutional symptom. So for the clinical manifestation, as I mentioned just now, most people will have few or no symptom, but there is some patient will experience generalized or non-specific symptom and signs, such as fatigue, sweat, weight loss, and also persistent lymphadenopathy. And in this chronic phase of infection, patients are either asymptomatic or develop minor opportunistic infection, such as oral candidiasis, vaginal candidiasis, herpes zoster, and perhaps mycobacterial tuberculosis. Autoimmune thrombocytopenia may also be noted. So for the opportunistic infection, I will discuss it in detail in the following slide. So we will come to the stage 3, that is early symptomatic stage. So in this stage, the plasma volume will increase, accompanied by a more rapid decline in the CD4 count. And over the time, the immune system will become damaged and weakened by the HIV virus, and the symptoms will develop. So for the clinical features, for example, they will have unexplained diarrhea for more than 1 month, mild opportunistic infection, unexplained weight loss, unexplained fever, fatigue, night sweat, and also some patients will also develop a comorbid condition such as cardiovascular disease, renal disease, osteoporosis, cognitive dysfunction, and also certain malignancy. So these are the pictures show oral candidiasis, same as just now, and also oral hairy leukoplakia. So now we come to the last stage of HIV, that is AIDS, acquired immunodeficiency syndrome. So for AIDS, it is the last stage of HIV and is the outcome of chronic and symptomatic HIV infection and consequent depletion of CD4 cells. So based on Robbins and also Cochrane pathology, it defines AIDS as a disease caused by the retrovirus human immunodeficiency virus, that is HIV, and characterized by the profound immunosuppression that leads to opportunistic infection, secondary neoplasm, and also a neurologic manifestation. So the final phase is a progression to AIDS, characterized by a breakdown of host defense, a dramatic increase in plasma virus, and severe life-threatening clinical disease. Typically, the patient will present with long-lasting fever, such as fever more than 1 month, or fatigue, weight loss, diarrhea more than 1 month, opportunistic infection, and also malignancy. So in the absence of the treatment, such as ART treatment I mentioned just now, most but not all the patients with HIV infection will progress to AIDS after chronic phase lasting from 7 to 10 years. So these are syndromes that will develop in the AIDS state. First one is carboxysarcoma. It's characteristic by the coalescent cutaneous red, purple, maculous, and plaque, for example, shown in diagram. And also pneumocystic pneumonia, that is a serious infection caused by the fungus pneumocystic gyrovecii, a yeast-like fungus. And actually, pneumocystic pneumonia is the most common opportunistic infection of HIV positive patient, and subsequently, many will develop into ARDS. And the definitive diagnosis can be done by induced sputum and also bronchoalveolar lavage. So that's the question, like how we gonna detect the patient that may develop AIDS? So there is some condition. Firstly, the patient with CD4 T cells less than 200 per microliter, or the patient that have HIV and one or more AIDS defining illness, no matter how many CD4 counts a person has, and also a laboratory investigation is always a confirmation test. So these are the summary for the stage according to the number of T lymphocyte count and also percentage, which I get from WHO. So there is some common clinical presentation of HIV in adult and children. You guys can refer to it later for this part. Okay, so I'm gonna to continue my presentation about the opportunistic infection. Opportunistic infection are infections that occur more frequently and also more severe in individuals with weakened immune system, including people with HIV, and is considered as AIDS-defining illness, as I always mentioned just now. And opportunistic infections are less common now than they were in the early days of HIV and AIDS, because nowadays we have better treatments to reduce the amount of HIV in a person's body and keeps the person's immune system stronger. However, many people with HIV still develop opportunistic infection because they may not know of their HIV infection, or they may not be on treatment, or that treatment may not be keeping their HIV levels low enough for the immune system to fight off the infection. So this is just exposure to the HIV-related infection and also illness, and its classification based on the microorganism. So these are the list of the most common opportunistic infection in HIV patient. I will discuss it one by one. So for the first one, pneumocystic gyrovectory. In the previous year, we call it as pneumocystic carini. It's caused by the organism pneumocystic gyrovectory and is originally thought to be protozoa, but now classified as fungus. It's a very common infection in AIDS and is fatal if untreated. For the presentation, such as chest pain with coughing, shortness of breath, and also include extrapulmonary infection. So these are the pictures show the infection of the lung by this pneumocystic gyrovectory. So for the cryptococcis, it's caused by the Cryptococcus neoformans (SP) and is encapsulated urease positive yeast. Is found in the bird droppings and is a symptomatic infection by the pulmonary route and is leading symptomatic fungal infection in the AIDS. So these are the example. We can see like the lesion at the face and present as papule, plaque, and also nodules and ulcer. So for the Cryptococcus neoformans (SP), it is a encapsulated yeast and obligate aerobe and most like target lungs and also central nervous system of immunocompromised individual. And humans do not transmit these Cryptococcus neoformans to another human. It's usually infected via the inhaling of the dust that contaminated with the bird feces, that is the bird droppings I mentioned just now. So for the next one, Mycobacterium tuberculosis, which we all know it is a causative agent of tuberculosis and is an acid-fast bacilli and also an airborne microorganism. It can spread from person to person, such as when talking to each other, spitting, and also coughing, and it usually targets the lung. I mean, we can diagnose using the Zell-Nielsen staining. So there are 2 to 10% annual risk of infection of Mycobacterium tuberculosis if the HIV is positive. So for the presentation, they will have rapidly progressive disease on primary infection and also extrapulmonary disease more likely as CD4 cells decline. There's another one that is Mycobacterium avian complex, which we know as tuberculosis in birds. If in human, it's called a Mycobacterium intracellular. So the presentation includes fever, night sweat, weight loss, and also pulmonary infection in known AIDS patient. Sorry. So for cytomegalovirus, it can be transmitted from one person to one person by close contact with the virus. And the virus may shed in urine, saliva, semen, breast milk, cervical secretion, and also carry in circulating blood cell. So these are the clinical presentation. For the cryptosporidosis, is a waterborne disease and self-limiting infection in the normal children, and it can cause chronic watery diarrhea in AIDS and can be life-threatening. So the most important clinical presentation for cryptosporidosis is diarrhea, and also include others such as fever, nausea, vomiting, weight loss, stomach pain, and also dehydration. So how transmission of HIV occurs actually has mentioned by Yusuf just now. So the transmission of HIV, that is virus, can transmit through direct contact with certain body fluids like blood, rectal fluids, vaginal fluids, breast milk, and HIV in this fluid must get into the bloodstream of an HIV negative person through a mucous membrane, open cuts or store, or by direct injection. So the mucous membrane are found in rectum, vagina, mouth, and also tip of penis. So these are three main routes for HIV transmission. That is also mentioned by Yusuf just now, include the sexual route, the blood or blood product route, and also mother to child route, that is the vertical transmission. So this is a summary. You can get HIV via sex with a condom, pass from mother to baby. There is a vertical transmission, sharing injecting equipment with HIV positive people, and also contaminated blood transfusion, and also organ transplant. You can't get HIV from kissing, hugging, sharing food, insect bites, toilet seats, laughing, sneezes, and also cough. So that's my presentation today. So if you guys have any problem, kindly leave the question in the chat box. I can answer to it after the presentation. Thank you. So I will pass to the next presenter. Thank you.
Okay, hi, and good morning, everyone. My name is Moafa, and my topic today is HIV lab diagnosis. We're going to have a little bit of an intro to the approach and some important terms, and then we're going to dive into the test methods, which include the serologic and molecular methods, as well as why you can get some false positives and false negative test results in HIV testing. And then we're going to apply all the knowledge into the algorithm test strategy and also the seroconversion of each test. Okay, so starting with the basics, my friends have covered a lot of this, but to recap quickly, so HIV is a bloodborne virus, transmits via sexual intercourse, specifically without protection, and also intravenous drug paraphernalia, especially drug use, such as heroin abuse, and vertical transmission from mothers to babies, caused by HIV-1 or HIV-2 retroviruses. And the symptoms are non-specific, which can be problematic because the patient may come with diarrhea, or as Yvonne mentioned, diarrhea, or just non-specific symptoms, which makes it hard to identify what the problem is. HIV can also be asymptomatic for years or even over a decade. This also causes a lot of late diagnosis. Okay, so some important terms. This have been also covered by Yvonne. So I'm going to spare you the graph. She already explained it really well. So CD4 plus T cell count indicates the current risk of acquiring opportunistic infections. And so the lower your CD4 plus T cell count, the higher your risk of getting opportunistic infections and diseases like tuberculosis and sepsis. The viral load means or refers to the amount of virus that you have in your blood. So this is used as a surrogate marker for the viral replication rate. And then you have seroconversion. So seroconversion can be different for each test, but it generally indicates the period of time where your body starts producing detectable amounts of HIV antibodies. So yeah, so for each test, it can be different. Okay, so this is the graph explained by Yvonne already, pretty well. Okay, so we move on to the methods of testing. So firstly, we have symptomatic and high-risk individuals. This is a straightforward case. We're going to talk more about this in the algorithm and the strategy of testing. And we have asymptomatic and low-risk individuals. This can be a more complex procedure. And then we have like the patients who are misdiagnosed, or if we have a lot of inaccuracies, it can cost a lot of patients severe or tremendous economic, social, and psychological distress and costs. That's why we need to apply the algorithm and the strategy precisely and with proper equipment and with good tests that have high sensitivity and specificity. So the methods of testing in HIV are actually three. So it's virological methods, serological methods, and molecular methods. Virological methods, which include viral culture, for example, are a little bit clinically insignificant because they're more valued in research purposes. So they're usually used in research. But we have these serologic methods, which are very commonly used. So we have antigen detection. So antigen detection usually looks for the P24 capsid, which is detectable by enzyme immunoassays. And we have, usually high titers or high concentration of the P24 capsid before seroconversion. So before the body starts to produce a lot of antibodies that are detectable. So this is good for if you want to test early, if you want to catch the virus and start treatment early before developing the virus. So this is at day 7 to 14. We can usually find the P24 capsid. And after seroconversion, after the body starts producing antibodies against HIV, the P24 can get complexed with P24 antibodies, which can make it harder to find. And then we have, so later when you have a clinical progression of the disease, you might see a resurgence of P24 capsids. So these tests usually detect around 4,000, more than 4,000 virions. And there are some interfering substances that can cause false positives. Okay. So most cases of HIV are diagnosed using, or first are tested using antibody HIV-1 and HIV-2. So seroconversion in third generation. So we're going to talk about the generations in a bit. So third generation antibody tests, the mean seroconversion of that is 22 to 25 days. Fourth generation antigen antibody tests are a little bit faster. So yeah, so they're more commonly used, even used in USM. So that's 5 to 10 days sooner. They have great sensitivity of 99.9%, specificity of 98.8%. Okay. So antibody testing usually is a two-stage process. So you start with an immunoassay, an antigen antibody immunoassay, and if it's repeatedly reactive, then you go to a confirmatory assay like line immunoassays. Okay. So HIV antibody enzyme immunoassay. Antigen preparation can be divided into three types. So these generation tests are basically it has to do with how the antigen is made for these antibody tests. So the first generation simply uses infected T cell lines, line lysates. Second generation uses recombinant proteins. So they take the genes that code for the protein and then put them in E. coli, and they make the proteins that way. We have third generation and fourth generation tests. These use also recombinant antigens, but also oligopeptides. Okay, so this has been the development of HIV diagnostic testing, or the evolution of it. So as you can see, as we come closer to the fourth and fifth generations, we have higher specificity, we have higher sensitivity, we have a smaller negative window, which is really important to, to identify quickly the, also to eradicate some false negatives, which when people get tested during the negative window. So what's special about the fourth generation is that it can test the P24 antigen. That's why that's one of the reasons why it has a negative window that is smaller than third generation. So the results of fourth generation, or most of these tests, do not tell you whether it's antibody or antigen. So they don't tell you whether the person has antibodies or antigen that caused the positivity. So it's either just reactive or positive or negative. However, the new test, fifth generation, can actually separate HIV-1, HIV-2, and can tell you whether it's an antigen or an antibody. So yeah, that's significant if you want to know if you want to know if the patient has developed the antibodies yet. Like, you can know it's a recent infection. Okay. So regarding the third and fourth generation enzyme immunoassays, we have two main tests. These are the first step in the algorithm, which are ECLIA and ELISA, electrochemiluminescence immunoassay analyzer. So that's ECLIA, that's used in USM. And then you have enzyme-linked immunosorbent assay, ELISA. So this will determine the antigen presence. So it will be either reactive or non-reactive. It will tell you, it won't tell you how much antigen is there, but it will tell you whether there is or there is not. So ECLIA has a superior assay performance to ELISA. And the results can be determined automatically by the software or manually. But we're going to see some interpretation, or how to interpret reactive and non-reactive results in the algorithm later. Okay. So we also have rapid tests, and these are membrane enzyme immunoassays and immunochromatographic tests. So they can be done with oral or blood specimens. So they're very simple to do. They're like COVID self-test almost. So they have good sensitivity and specificity actually, but this is only in ideal conditions. So if they're done by laboratorians, so if they're done in a clinic or in the ER, it's not really a good test. So That's why it has lower sensitivity and specificity in field, so in the medical field. Okay, so these can actually detect antigen. Well, some of them at least, the new ones, and they can be pretty expensive, and they have longer time to positivity. It is recommended that this test is kept around for women that come in labor, for example. Like in situations like that, it's not, you shouldn't use this test for your convenience or for the patient's convenience to, if he wants to know now, or you just want to do it in your clinic instead of sending the sample to somewhere else. No, that shouldn't be done because it's not an accurate test. And when you do the test, you have to actually start a new algorithm, even if whether it's negative or positive. You need to start a new algorithm. So it's recommended to be done on women who come and they go into labor, and you really don't have time to do any other tests, and they don't have any prenatal care, so you don't know whether they have HIV. So you can, prevent the vertical transmission. Yeah. So also you have needle stick injuries where you need a short turnaround time to start prophylactic therapy. Yeah. So if you accidentally in the I don't know, clinical years have a HIV patient, you accidentally have a needle stick injury, that's probably a test that's gonna be done. So if reactive, you must enter a new algorithm, as we have mentioned. Okay. So other confirmatory assays, we have the multi-spot test, which differentiates HIV-1 from HIV-2. And we have indirect immunofluorescence tests, which can screen or confirm the tests that are before, like immunoassays. And then we have line immunoassays, which are similar to Western blot, but well, they have higher specificity and they're faster generally. They have a shorter negative window. And that's one of the reasons why Western blot is actually not in the algorithm anymore. Western blot has been outdated already for HIV specifically. Okay, and then you have nucleic acid testing. This is a very specific test, although really expensive. We're going to talk about it more in the molecular methods. So line immunoassay, in USM, they use this test called INNOLIA, HIV-1 and 2 score. So this is the term that you're going to get familiar with in the clinical years. They use recombinant proteins and synthetic peptides from HIV-1 and HIV-2, and a synthetic peptide from HIV-1 group O. And they're coated as discrete lines, you can see here, on a nylon strip with plastic backing. So this test is used in USM, and it's very good to confirm the presence of antibodies against the HIV-1, including group O, and HIV-2 in human serum or plasma. So yeah, so good to differentiate the HIV-1 and HIV-2, and we'll talk about it more in the algorithm because yeah, that's where you apply everything. Okay, so molecular methods, we have qualitative proviral DNA PCR. So this test is going to be looking for DNA compared to others, which look for RNA. We're going to talk about it. This is going to, okay, this detects it actually in the peripheral blood mononuclear cells. And this is an integrated virus which targets, so this test will target the GAG and the POL gene. It targets the DNA. That's the main thing. And it has a near 100% sensitivity and specificity, which is really good. However, it's, as you can see, it's a bit lower in field, so in the clinic or in other situations, settings, you can have a lower sensitivity and specificity. So this test is not commonly used for diagnostics. However, it's really good to be used in neonates. So at birth, if you suspect HIV in the baby, you do this test on the baby, and if negative, then you repeat the test 2 more times, one from 4 to 7 weeks. And if negative, then you repeat it at the 8th week to 16th week. And yeah, so however, if it was positive at birth or any of the times where you tested, then you just stop. You just know that the baby has HIV and you start treatment. Yeah, otherwise you need to do it 3 times. So a qualitative TMA, this is a less commonly used test, but has a good sensitivity of 13 copies DNA. And it has an early diagnosis, so 6 days before P24, so that's really early. So this is good for blood donor screening, which detects rare units, negative for antibodies, and the risk for this is 1 in 2 million units, so pretty low risk. It can also be used in diagnosis for neonates and as a confirmatory test, resolve indeterminate Western blot. And that's kind of why it's not really used much anymore, because Western blot is not really used anymore. It's not recommended anymore by the CDC. Okay. So now we have the greatest test, I would say. It's like the final test. It's the test where it's the most expensive and not the most expensive, but it's really expensive. And it's the test that really determines whether you have any HIV DNA or you don't. So sensitivity is 100%. It is used by USM. So USM, if they suspect you have HIV, they'll take a blood or serum sample and send it to KL, because we don't have this equipment actually in USM. But they send it to a company called Synapse, and you get the results in about a week. So this test that's used in USM is Proclex ultrassay. Okay, but another test that can be done is Aptima HIV1 quantitative DX assay, diagnosis assay. So this test can detect the RNA of the virus 10 to 12 days after exposure, and is a very good and reliable confirmatory test. Okay. So what can cause false results, false positives and false negatives? So this can happen due to many things. It can happen due to poor record keeping, or mishandling, or mixing up blood. It can happen through mistakes in the hospital. But it also can happen, like in this instance, false positive can happen if you have hematological malignant disorders, autoimmune disorders, multiple myeloma, primary biliary cirrhosis, or alcoholic hepatitis, chronic renal failure, or even pregnancy. You can have false positive due to these risk factors. And for false negatives, you can have it due to being tested during the window period, the negative window period. Yeah, you're not going to have any positivity reaction, any reaction if you test during that time. And also if you have immunosuppressive therapy. By the way, I really apologize about the sound if you can hear it. We have construction right next to us. Anyways, also, if you have B-cell dysfunction, that can cause a false negative, or bone marrow transplantation. Also, if you're in a late stage of HIV infection, or you're already, if you've already been diagnosed by AIDS, this is one point. Okay. So we go into the algorithm. So this is where we can apply everything. Okay. So starting with the antigen antibody immunoassay. So in USM, as we have mentioned, the test that is used is ECLIA. And here in if you want to order this test, you just say ECLIA. And then if, so for antibody differentiation immunoassay, this test is in NOLIA. So they used line immunoassay in USM. And then for NAT, then it's just known as NET. Okay. So you test the patient, you order antigen antibody immunoassay. Patient is negative, then that's it. It's negative, except if you suspect recent activity or recent risk. If the patient, I don't know, had recent drug use or something, then what you should do is go immediately to NAT. Skip the differentiation immunoassay because they probably, if it's recent, they probably haven't developed the antibodies yet, because differentiation immunoassay don't test for antigens, they test for antibodies. So you just go for the NAT test immediately, and some NAT test for HIV too as well. Okay, so if the patient is positive for antigen antibody immunoassay, then you do the line immunoassay called an USM, or the differentiation immunoassay, which will tell you which HIV it is, if it's HIV-1, HIV-2. Yeah, so if it's positive, then you know it's positive. Then after that, you probably need to do some, start medications and start treatment. However, if it's negative or indeterminate, then you have to do an NAT test, because as we have mentioned, the patient could have the antigen, but not the antibodies just yet. They haven't developed. So you just go for the NAT test. So maybe this test have developed the or detected the antigen. So if you have the patient positive, then you just diagnose with HIV. And if the patient was negative for NAT, then that could just indicate that this test was a false positive. So the antigen antibody immunoassay could be a false positive if the NAT test was negative. However, in this case, this specific test, this specific NAT only tests for HIV-1, as you can see. So if it was HIV-1 negative, then the patient could be having HIV-2. Now, this is usually done with patients that have a high risk for acquiring HIV-2. And what you're going to do then is order HIV-2 specific nucleic acid testing. I think that's all for the algorithm and the testing strategies. And from my reading, it's really common for hospitals, especially in underdeveloped countries, to diagnose people who don't have HIV with HIV, and people that have HIV to say that they don't have HIV. And this is because they don't follow this properly. Like, I saw a lot of studies that say it's because they actually don't follow this algorithm properly. There's they missed a step, or they did the wrong test. It could be due to a lot of factors. So just follow it precisely, and hopefully it's going to be accurate. Okay. So here, this is the kind of seroconversion of some tests, or when the tests can be detected. So as you can see, NAT is the earliest, and then you have P24 antigen enzyme immunoassays, which include ECLIA and ELISA. So these are third and fourth generation, and even fifth generation tests. And then we have HIV P24 antigen. As you can see, it will peak after the onset of the infection, but then it will lower once you have antibodies that can make it harder to find, make the P24 antigen much harder to find, because they complex with it, they form a complex. Okay. And I think that's all. These are my references. If you have any questions, please have the floor and ask. Thank you. Okay, if there are no questions, unfortunately, our colleague Aisha is having a flight currently. She's flying somewhere, probably here or back home. So she made a she pre-recorded her presentation. So I'll be sharing her presentation. So just let me know if you can hear or cannot hear. Okay.
Good morning to Doctor and everyone. I am Aisha Marini binti Muhammad Razif.
Can you hear?
Yes, we can hear it.
Okay, great.
So I
Is there no sound?
Yes, for now. We
Okay.
can't hear. Yeah.
Okay, sorry. Okay, 1 second. Let me change the settings.
defining illness actually. So AIDS-defining illnesses are diseases that occur in people living
About
with
now?
HIV. They are one of the indications that HIV has progressed to. Good morning to Doctor and everyone. I am Aisha Marini binti Muhammad Razif. So I will discuss about AIDS-defining illness and the management. Here are the outlines for my part. What is AIDS-defining illness actually? So AIDS-defining illnesses are diseases that occur in people living with HIV. They are one of the indications that HIV has progressed to AIDS, which is the most severe form of the disease. So in other words, when certain serious and life-threatening diseases occur in HIV positive people, they are called as AIDS-defining illnesses. And when a person gets one of these illnesses, he or she is diagnosed with the advanced stage of HIV infection known as AIDS. So AIDS-defining illnesses can differ in severity, and some occur more frequently than others, and also it can be in the form of infection or cancer, which we will be discussed later on. Okay, for opportunistic infections, if there is any deterioration of the immune system that is caused by the decline in CD4 plus T cells, where CD4 plus T cells, it is the key for the infection fighters. And as soon as HIV enters the body, it begins to destroy these cells. And because people with AIDS have weakened immune systems, they are more prone to infections, which that is called as the opportunistic infections. And opportunistic infections are caused by organisms that typically do not cause disease in healthy people, but affect people with damaged immune systems. And these organisms attack when there is an opportunity to infect. So opportunistic infections can be caused by the bacteria, viruses, fungi, and protozoa, which are common in the immunocompromised patients. Um, some AIDS-defining illness are opportunistic infections, but not all. For example, candidiasis, it is an opportunistic infection because candida yeast commonly live in humans without causing illness. But pneumonia, it is not an opportunistic infection because microbes that are caused that cause it are always harmful to the body. The most common opportunistic infection occurring in HIV-infected individuals is pneumocystis carinii pneumonia. A fungus known as Pneumocystis jirovecii causes this type of pneumonia, and it is a major cause of infection in people with HIV, with nearly 400,000 cases worldwide each year. And in 80% of cases, it is the first indicator of the development of AIDS. Usually, these patients will have CD4 plus T lymphocyte counts of less than 200 cells per cubic millimeter. Symptoms of PCP may include dry cough of more than 5 days, fever, and difficulty in breathing. In physical examination, they may show minimal signs, but more advanced infection will include acute breathlessness, cyanosis, and presence of respiratory rales. But in the early PCP, they may be asymptomatic. So for the treatment of PCP, we can use antibiotics such as cotrimoxazole, trimethoprim, and sulfamethoxazole. Secondly, toxoplasmosis. Toxoplasmosis, it is a Toxoplasma gondii infection, and it is the most common opportunistic infection affecting the central nervous system in HIV-infected individuals. This infection occurs when CD4 plus T cell count is less than 100 cells per cubic millimeter, and patients can present with headache, fever, confusion, and convulsions. And the use of MRI of the brain is more sensitive in detecting the lesions in the brain. So a therapeutic of trial of anti-toxoplasmosis such as sulfadiazine and pyrimethamine is used for the treatment. The most common fungal infection is candidiasis, which is caused by the Candida albicans. In the early stages of the progression to AIDS, the patient may complain of painful lesions in the mouth. Subsequently, the symptoms become worse with burning pain in the throat during swallowing. And by this stage, the patient is likely to have oropharyngeal candidiasis, and esophageal candidiasis can be recognized as a defining illness. At this stage, the CD4 plus T lymphocyte count would be below 400 cells per cubic millimeter, and candidal infection can also affect other organs like the gut, liver, central nervous system, and the respiratory system. And for the treatment, we can use antifungals such as ketoconazole, itraconazole, or fluconazole. Next, cryptococcal infections, which are common in immunocompromised patients, especially when their CD4 plus T cell counts are less than 100 cells per cubic millimeter. And these infections are due to Cryptococcus neoformans, which is usually isolated from the soil, but the most common source of the virulent strains are from pigeon droppings, which are encapsulated and upon contact with human beings, rapidly develop capsules. So the causative organisms are C. neoformans, Var. neoformans, and Variegaceae. The infection is probably well established in the lungs and other viscera before disseminating to the brain and meninges. And in AIDS patients, disseminated cryptococcal infections is the fourth most common cause of life-threatening illness. And under cryptococcal infections, we have cryptococcal meningitis and pulmonary cryptococcal infection. So for cryptococcal meningitis, this form of meningitis results from cryptococcus that causes inflammation in the brain and spinal cord. And the involvement of the central nervous system with cryptococcal meningitis is the most common, occurring in about 85% of those with cryptococcal infections, where the symptoms including fever, headaches, meningeal signs, altered mental status, cranial nerve palsies, motor abnormalities, cerebral signs, and occasional fits. While for pulmonary cryptococcal infection, The respiratory infection is usually asymptomatic and may only be an accidental finding during a chest radiological examination. Occasionally, pulmonary cryptococcal infection can manifest with chronic cough, weight loss, low-grade fever, hemoptysis, dyspnea, night sweats, and malaise. Histoplasmosis is due to the fungus Histoplasma capsulatum. It can enter the lungs and cause infection long after initial contact with the fungus. And the symptoms may be flu-like, including fever, weight loss, and fatigue. And histoplasmosis becomes AIDS-defining when the fungus spreads outside the lungs and affects other parts of the body. And this may cause liver or spleen enlargement, pulmonary symptoms, and adrenal gland issues. In HIV-infected patients, histoplasmosis is disseminated in 95% of the cases, and 90% of the cases is CD4 counts below 200 per cubic millimeter, and the treatment can be used. We can use antifungal, liposomal amphotericin B, and itraconazole. Aspergillus infections. Systemic aspergillosis is the most common invasive fungal infection in the immunocompromised host. The common pathogenic species are Aspergillus fumigatus and A. flavus. Infection with Aspergillus species can present in many ways, such as allergic aspergillosis, aspergillomas in the lungs, superficial aspergillosis, chronic necrotizing pulmonary aspergillosis, and invasive aspergillosis with pulmonary involvement and extrapulmonary dissemination. And the clinical manifestation of invasive pulmonary aspergillosis includes unremitting fever and new pulmonary infiltrates in spite of broad-spectrum dyspnea, non-productive cough, sudden pleuritic pain, fever, tachycardia, and sometimes with a pleural rub, may mimic pulmonary embolism, hemoptysis, and night sweats. So for this treatment, we can use long-term antifungal therapy, which is the mainstay in managing patients with aspergillosis. And antifungal itraconazole is given for 12 months in case of disseminated aspergillosis. Furthermore, we have mycobacterial infections for AIDS-defining illness, where tuberculosis occurs due to the Mycobacterium tuberculosis bacteria. And the World Health Organization, WHO, estimates TB to be the cause of death in 13% of people with AIDS, where the symptoms for this including cough, tiredness, weight loss, and fever. Pulmonary TB in a HIV-infected patient doesn't necessarily mean they have AIDS, because AIDS can be only classified in people who are HIV positive and has CD4 plus counts below 200 cells per cubic millimeter. So for the treatment, it is along similar lines as non-HIV infected individuals. However, in HIV infected patients with tuberculosis, lifelong therapy with isoniazid and rifampicin should be given. Okay. Another one under mycobacterial infections is Mycobacterium avium complex. Typical as well, atypical mycobacterium infections are common among patients with AIDS, and their clinical presentations can be prolonged fevers, severe weight loss, and chronic diarrhea. This infection caused by atypical mycobacteria such as Mycobacterium avium intracellular and M. kansesi are very common in HIV-infected individuals when their CD4 plus T lymphocytes fall below 100 cells per cubic millimeter. And then we also have cytomegalovirus infection, which usually occurs between 50 to 100 CD4 plus T lymphocytes per cubic millimeter. And this cytomegalovirus infections is not very common in immunocompetent individuals. However, in immunocompromised HIV-infected individuals, the virus can affect the eyes, causing retinitis and subsequent blindness. And it also can cause increased floaters in the eye or a loss of peripheral vision. And the infection of the gastrointestinal tract can occur with the symptoms of colitis and severe weight loss, while the respiratory system can also be affected with pneumonitis. And for the treatment, we can use antiviral to treat. For viral infection, herpes simplex virus is categorized here, where herpes simplex infection occurs when CD4 plus T cell counts fall to below 400 per cubic millimeter, and it can cause cold sores or genital herpes, which are painful blisters in the genital area, and the lesions are usually erosive. And for the treatment, Zofirax has been found to be effective in treating the herpes infections. Additionally, isosporiasis, which is caused by Isospora belli, it is a unicellular parasite and it can affect the gut, causing profuse diarrhea. So the symptoms of weight loss and malabsorption may be seen, and the weight loss due to Isospora infection can be very severe, and the patient may present with emaciation and severe dehydration. And it can be treated with high-dose trimethoprim and sulfamethoxazole. And then cryptosporidiosis. Um, it is caused by Cryptosporidium, also a type of unicellular parasite that can cause profuse diarrhea in immunocompromised patients. Cryptosporidiosis can occur between CD4 plus T cell counts of 50 to 100 per cubic 50 to 100 cells per cubic millimeter. Okay, and it causes severe weight loss and dehydration. And for the treatment, there is no definitive treatment for this infection. Moving on to cancer and AIDS defining illnesses. So people living with HIV or AIDS are much more likely to get certain types of cancer than people without HIV or AIDS. And AIDS-defining cancers, including Kaposi sarcoma, aggressive beta cell, non-Hodgkin lymphoma, and cervical cancer. And HIV affects the way the immune system works. This may be what increases the risk for certain cancers. And other cancers linked to HIV or AIDS are head and neck, anal, lung, testicle, skin, and liver cancer, as well as Hodgkin lymphoma. Kaposi sarcoma, this is the most common AIDS-related cancer, and it is a tumor of the blood vessel. Kaposi sarcoma or KS, so classical KS occurs commonly among elderly males of Mediterranean descent, and KS is related to an infection with human herpes virus 8, and these tumors are usually confined to the lower limbs. However, the appearance of KS in previously healthy young males will suggest the presence of concomitant HIV infection. In such situations, the lesions are usually numerous and fairly extensive, and it can appear as raised or flat pink or purple reddish spots or lesions on the skin. So the lesions of Kaposi sarcoma are not only confined to the skin, any organ in the body may be involved, and the involvement of the lungs with KS may cause hemorrhagic pleural effusion. So, lymphoma. This is a cancer of the white blood cells or lymphocytes. A patient with HIV is 10 to 20 times more likely to develop non-Hodgkin lymphoma and about 8 times more likely to develop Hodgkin lymphoma than a person without HIV. So the symptoms of lymphoma depend on where the lymphoma is and what type of lymphoma that the patient have. And the most common types of lymphoma in people with HIV are high grade, which is the fast growing. So symptoms can come on quickly over a past few weeks. And initially, most people will find a lump or a swelling, often in the neck, armpit, or groin. This is a swollen lymph node. And if lymphoma grows in the abdomen or bowel, patient might get abdominal symptoms like abdominal pain, swelling, nausea, vomiting, or diarrhea. And lymphoma can also develop in the chest, which might cause a cough or shortness of breath. And many people with lymphoma and HIV also have general symptoms that often occur together, like unexplained weight loss, fevers, which are the temperature over 38 degrees Celsius, and night sweats. All right, that is all for the AIDS defining illness. So let's go to the management of HIV and AIDS. So the treatment for HIV is called antiretroviral therapy, ART. So ART involves taking a combination of HIV medicines, which is called an HIV treatment regimen. Since 1996, the management of human immune deficiency virus (HIV) infection has been revolutionized to highly active antiretroviral therapy (HAART), and it is usually consisting of 3 or more antiretroviral drugs that act on different targets in the virus. And HAART is synonymous with antiretroviral therapy and combination antiretroviral therapy, and ART has dramatically reduced opportunistic infection-related mortality among HIV-infected persons, improved quality of life and survival, and with ART, HIV has become a chronic manageable disease. But actually, ART cannot cure HIV, but it helps people with HIV to live longer, to have healthier lives, and ART also can reduce the risk of HIV transmission. How do HIV medicines work? The HIV medicines prevent HIV from multiplying, which reduces the amount of HIV in the body. That is called the viral load. And by having less HIV in the body, that gives the immune system a chance to recover and produce more CD4 cells. And even though there is still some HIV in the body, the immune system is still strong enough to fight off infections and certain HIV-related cancers. Factors to consider before initiating ART. Basically, the initiation of antiretroviral therapy must be a carefully planned decision following thorough evaluation and informed discussion between the healthcare provider and the patient. So the patient's willingness to initiate and adhere to treatment is of the utmost importance. This should be done with the patient's full comprehension of the rationale of treatment, and the patient should understand the need for strict adherence and regular medical follow-up, the adverse effects and immune reconstitution associated with treatment, their implications and management. Another factor to consider and the patient should understand is what are the antiretroviral options that are available to them. And the next factor is the regimen must be based on factors related to the patient and the virus with long-term disease control as the major goal. Regimen should be individualized after assessment of the following, which are the underlying risk factors or medical disease that will predispose to adverse effects of antiretroviral agents, for example, cardiovascular risk factors, metabolic syndrome, diarrhea, and others. We also need to assess the drug-drug interactions, dosing frequency, and pill burden before initiating ART to patient. And other factor that need to be considered is the risk of primary resistance or viral factors that will suggest the resistance, like acquisition of HIV from a partner who is on treatment. And lastly, the patient factors that may hinder adherence, such as irregular working hours, depression, gastrointestinal disturbance. The goals and benefits of ART include to reduce HIV-related morbidity and mortality, to improve quality of life, to increase lifespan, to restore and preserve immunologic function, and then highly active ART using 3 or more active anti-HIV drugs from at least 2 different classes with the aim of achieving durable viral suppression to undetectable levels, regardless if it is the first or subsequent regimen. This is the therapeutic goal under most clinical circumstances. Moreover, there are also to reduce in complications associated with HIV, AIDS, such as wasting syndrome, age dementia, and encephalopathy. On top of that, to prevent HIV transmission to an infected sexual partner and the unborn child, apart from to prevent emergence of HIV drug resistance. Okay, based on MOH, the treatment outcomes may be measured from these three aspects. First, clinically by the reduction in the number and frequency of opportunistic infections and improvement of general well-being. Secondly, immunologically, by gradual and steady rise in CD4 T cell counts. And third, virologically, by a decrease in viral load, ideally to undetectable level at 6 months after initiation of treatment. For ARV drugs available in Malaysia, the ART options have expanded greatly since the first drug, zidovudine, was approved in the US in 1987. And currently, there are 6 classes of ARV drugs which target different phases in the HIV life cycle. And Table 1 shows the list of currently available ARV drugs in Malaysia. And this table shows the various type of drugs in 6 classes that could be used for ART in Malaysia. They are nucleoside or nucleotide reverse transcriptase inhibitors such as abacavir, amitriptyline, and lamivudine. And for non-nucleoside reverse transcriptase inhibitors and NRTI such as efavirenz, etravirine. And for protease inhibitors, we have atazanavir, darunavir, and then integrase inhibitors such as raltegravir and dolutegravir. CCR5 antagonist, we have marivarog, and lastly, fusion inhibitor, we have enfuvirtide. And then for fixed dose combination drugs, FDC, they are multiple ARV drugs combined into a single tablet. See table 1.2. So table shows fixed dose combination drugs registered in Malaysia. For example, under brand name Kivexa, they have 2 combination drugs, which is abacavir and lamivudine. And Trivizir have 3 combination drugs. Claptera and Combivir have 2 combination drugs. So these fixed dose combination drugs, they will reduce pill burden and cost, and dosing simplification improves the patient compliance to treatment and maintain durable virological suppression. Next, we have to know the factors to consider before initiating the antiretroviral therapy. So ART is recommended for all HIV-infected individuals, regardless of CD4 count, to reduce the morbidity and mortality associated with HIV infection. It is also to prevent HIV transmission. So the summary of recommendation for individuals without opportunistic infection is shown in table 4.0 below. So all HIV patients above 18 years old are recommended to start with ART regardless of the CD4 count. However, as priority, ART should be initiated in all adults with severe advanced HIV clinical disease, who clinical stage 3 or 4, and individuals with CD4 count less or equal to 350 cells per millimeter cubic, HIV-associated nephropathy, HIV hepatitis B virus co-infection, HIV hepatitis C virus co-infection, and all pregnant ladies infected with HIV. So these are the priority that ART should be initiated. So if they have factors to start ART in individuals without opportunistic infections, then they must also have the factors to start ART in individuals with opportunistic infections. So starting ART in the event of acute OI, the opportunistic infections always remains a great challenge, and delaying ART till completion of OI therapy will increase the risk of progression to AIDS and death. And drug-drug interactions, additive adverse effects, high pill burden, patient adherence, and paradoxical reactions may also pose problems. And so MOH guideline recommends clinical assessment at the end of 2 weeks of OI therapy. And if patient is stable and has improved with OI treatment, the initiation of ART can be considered. So in patients with opportunistic infections for which no effective treatment is available, such as cryptosporidiosis, microsporidiosis, progressive multifocal leukoencephalopathy, and Kaposi sarcoma, the ART itself can result in improvement and hence should be initiated as soon as possible. However, in the following conditions, the timing of the initiation of ART varies according to specific circumstances. Firstly, for tuberculosis, ART is recommended in all HIV infected persons with TB, and it should be started within 2 weeks when CD4 count is less than 50 cells per cubic millimeter, and by 8 to 12 weeks for all others. And in patients with TB meningitis and low CD4 cell counts, early ART may pose a risk that calls for careful monitoring and consultation with experts. Secondly is cryptococcal meningitis, where delay initiation of ART here at least until after completion of antifungal induction therapy, which is the first 2 weeks, and possibly until the total induction or consolidation phase, 10 weeks has been completed. And for other forms of cryptococcosis, initiation of ART by 2 to 4 weeks after starting antifungal therapy is also recommended. Okay, ARV drugs actually also have the adverse events or the adverse reactions themselves, and they can occur with all antiretroviral agents and are a major reason for switching or discontinuation of therapy and poor adherence. And differentiating between antiretroviral related toxicities and disease complications can be difficult. So the table showed adverse events toxicity of individual ARV with suggested substitution. So as stated here, ARV drug abacavir will cause a hypersensitivity reaction, the ADC. And then the suggested substitute ARV is TDF or tenofovir disoproxy fumarate or ZDV, which is the zidovudine. Then the TDF just now can cause renal tubular toxicity, Fanconi syndrome, decrease in bone mineral density, hepatic flares, and then the risk factors including underlying kidney disease, older age, BMI less than 18.5 kg, underlying diabetes mellitus, and uncontrolled hypertension. And so the substitute of the ARV here is zidovudine or abacavir. So zidovudine can cause anemia, neutropenia, myopathy, lipodystrophy, and the risk factors are baseline anemia or neutropenia, and the CD4 count is less or equal to 200 cells per cubic millimeter. So that are the risk factors, and it can be substituted. Zidovudine can be substituted with TDF or ABC. And then efavirenz, EFV can cause hallucinations, psychosis, depression, suicidal ideation. And so the substitute for ARV here is nevirapine. And if the patient keen to continue with efavirenz EFV in mild depression, that must closely monitor for deterioration of depression. So NVP, nevirapine can cause hepatitis, severe skin rash, and so the risk factors are females with baseline CD4 more than 250 cells per cubic millimeter, and males with baseline CD4 more than 400 cells per cubic millimeter. So nevirapine can be substituted with EFV or any protease inhibitors. Regarding the medical ethics in HIV and AIDS patient, firstly for the patient rights, right to confidentiality. So as a healthcare provider or social service provider, we cannot disclose by sharing an individual's HIV related information without written permission, except in limited instances in respecting the patient. And then the patient also have the right not to be mistreated on the basis of their health, of HIV status. Here we may apply the principle of justice, where there should be an element of fairness as well as equal distribution of treatments and scarce resources. In short, this means that the patient must be treated equally and care must be equally distributed. And then the patient's right to health is that they have the right to know all information regarding their medical condition and not to be denied their healthcare or treatment on the basis of their status. So it is the professional obligation of a medical professional to be reliable and accountable by giving the correct information on the basis of HIV status, and also guidance to the patient to make decisions on their health management for better care and treatment. Even if it's even if it is patient's autonomy to make decisions about one's own health and to be treated with respect and dignity and without discrimination. And then the patient also have the right not to be rejected in school or tertiary education on the basis of their HIV status, because no student shall be denied access to education just because of their HIV status. And the patient also have the right not to be terminated to work on the basis of the HIV status. All persons of working age have a right to work as long as he or she is capable of doing so and should not be debarred, dismissed, prohibited, or denied access to employment on the basis of their HIV status. For communication, communication is the key to success in the overall treatment of HIV and AIDS patients, because effective and good communication will build trust and rapport between doctor patient. This is to ensure that the patient have confidence and to encourage the patient to talk to the care provider regarding anything related to their conditions. Ineffective relationship between doctor-patient, confidentiality and privacy regarding all medical information related to their HIV/AIDS status should be maintained at all times. And this is important to build the patient-doctor trust. And we must be open and non-judgmental in understanding the patient. And we must let the patient know that they were heard, and we need to validate their concerns before quickly responding to the issue. So doctors must speak in proactive manner and must use words that's easy for the patient to understand to avoid any misunderstanding. So by having a good relationship between doctor patient, this also can help the patient to continue a lifelong treatment. Additionally, care provider need to counsel patient to adhere to medication. Patients should be educated about benefits of treatment and what may happen if medications are not taken as prescribed, because patients with poor understanding of their disease and medication regimen and their personal consequences of non-adherence are more likely not to take their medications properly. So doctor must understand each patient's medication taking behaviors. So by emphasizing on the importance of medication, so that the patient will adhere to the treatment and have a better life quality. Besides that, educate on the side effects also need to be emphasized. Patients who encounter side effects are less likely to stop taking the medication when they know about the potential side effects in advance. So providers should talk about these side effects and explain how to prevent an adverse drug reaction, and what is the likelihood of those side effects. Do they typically resolve without intervention, and how will the treatment plan change if they don't resolve? And we may ask the patients to repeat back the most important stuff and empower patients to ask questions. So this is to ensure that the patient will seek early treatment in case side effects occur after the treatment. Moreover, by teaming up with prescribers, with having a good communication and an efficient and team-based workflow benefits the pharmacy and the patients. With that, we may provide their contact numbers, names of staff, so that they can contact, the patient can contact regarding the medication, and we also have to provide when they can be contacted. So this is to ensure that the patient have easy access for medical treatment anytime needed. For insight, the challenges that could be obstacles to the success of treatment HIV and AIDS patient are Firstly, poverty as general factor that the patient doesn't want to seek medical treatment, especially if medical treatment is chargeable and they don't have enough income, something like that. And doctor may discuss with the patients regarding the financial aspects if needed, involving cost of medication and other therapy, that they might need financial assistance. And probably the patient also may have family problems such as they don't get enough support from family members to do the treatment and may will avoid them from seeking treatment. So the patient may lack of emotional and moral support from the ones that is close to her. So doctors can offer partnership to help with hospital counselor or a psychologist or therapist to give moral support and advice for the patient to prevent them from suffering overwhelming depression as a consequence of the condition. Therefore, it is important that they are aware of the supports that are available for them when needed. And the patient also may have full access to medical services. If patients don't have their own transport or don't get easy access to public transport, it may be difficult or hard for them to attend any medical appointments, and that can lead them to miss something that cannot be avoided. And if the patient have dissatisfaction with prior experience in the healthcare system, that will make them lose their confidence to continue and want further the treatment if they have that experience before. For example, they perceive lack of confidentiality before, and that will make the patient feel unsafe and left traumatized of what could happen next in their life now that everyone knows about their condition. So more solutions can be seen in the control and preventive measures next. Last but not least is the control and preventive measures of HIV and AIDS infection. So the goals of the HIV/AIDS prevention and control programs are to prevent further spread of HIV and to improve health outcomes for those already living with HIV. So let's go to prevention first. So first one is outreach and education programs. Like community-based outreach and education programs are actually key in improving access to HIV prevention and treatment services for key affected populations who are often marginalized due to stigma and discrimination. And outreach workers, a vast majority of whom are members of the key affected populations themselves, are deployed as peer educators to disseminate targeted information, education, and communication materials about HIV prevention, sexual and reproductive health, medical and legal aid referral services, as well as safe sex commodities such as condoms and lubricants. And so this program also aims to address gender and sexuality issues and drug use, violence, and other compounding factors that intensify HIV vulnerability. And then shelter care for people living with HIV. The Malaysian AIDS Foundation funded and in some cases helped to set up a number of shelter home facilities for people living with HIV in Malaysia. It is the place where they seek refuge as we provide them with a residential setting conducive for emotional and physical well-being. And services provided include basic nursing care, palliative care, medical referrals, and bereavement counseling, psychosocial, as well as a spiritual support service. Few examples of shelter care are Faith Home Kuala Lumpur, PKQM Shelter in Kuala Lumpur as well, Rumah Cakna in Terengganu, and here Rumah Sahabat in Kelantan. Okay, and then we also have hospital peer support for the prevention, where a trained team who work in hospitals to help provide services and to support the person live with HIV and help in daily work at the hospital associated with the PLHIV, and this peer support also implemented of home visit program. Drop-in centers are extension to outreach activities with the aim of providing direct services for key affected populations. And the services include facilities for maintaining personal hygiene and basic health care, warm meals, peer education, support groups, as well as referrals for voluntary HIV counseling and testing and legal aid. Okay. And then premarital HIV screening test. It is to ensure that the couples are HIV negative and to counsel the couples in case one of them or both are found to be HIV positive. And then needle and syringe exchange program and SEP. This is a social service that allows injecting drug users to obtain clean and unused hypodermic needles at a little or no cost, and it is based on the philosophy of harm reduction that attempts to reduce the risk factors for bloodborne disease such as the HIV and AIDS. And then that is for the preventive measures. Now, control measures. Wearing PPE for health workers by wearing protective gown, eyewear, mask or face shields with safety glasses or goggles during procedures that are likely to generate droplets or of blood or body fluids to prevent direct contact with the patient body fluid. And then must notify the partner of HIV individuals, HIV positive individuals. So this is to make sure that the partner is aware and should take precautions so that the disease is not transmitted to them. So ART during pregnancy to avoid transmitted. The next control measure is by consuming ART during pregnancy to avoid transmitting HIV to the fetus. So in pregnant women with confirmed HIV infection, the initiation of ART for maternal health is recommended for all women with CD4 cell counts of less and equal to 350 per cubic millimeter. And studies shown that ART during pregnancy can reduce perinatal transmission. Okay. The next one, I think the last one. Okay, last one is by avoid breastfeeding for HIV positive mothers. It is recommended that the mothers living with HIV not breastfeed to prevent HIV transmission to their infants because HIV virus could spread through the body fluids, including the breast milk. Okay, so here are my references that I use for this to prepare this presentation. That's all from me. Thank you for listening.
Okay, thank you, Marini, for your presentation. It was a really good presentation, very detailed, but it's actually a really big topic, the one that she took. So thank you very much for fulfilling it. Okay, Doctor, we've finished our presentations, so we're looking forward for your questions or feedback or from other students as well. So thank you very much for listening.
Hi, very good presentation, but I congratulate all the presenters. So it's a huge topic, so your friends can go through the slides again. I will put the link for the recording in the e-learning. Do you have any question? And don't forget the attendance. I have given your friend the QR code and the password. So if no question, we can end the session right now. Selamat Hari Raya. See you again.
Okay, thank you, Doctor, and thank you everyone for listening. Have a good day.
Thank you, doctor. Thank you, everyone.
Like